You all have been prompt in calling in, and although we had expected several others to call in, we'll go ahead and get started. First, for those of you on the phone, I would just like to say I'm so sorry you weren't able to attend our event today. We had a very nice lunch. We had a wide variety of people from different parts of the community throughout our 23 counties attend. And it was just a very nice sort of celebration and recognition of our first 2 years under waiver. What I'll let you know as we begin is that Brian Ingram, who is the CEO of Smoky Mountain LME MCO, will be talking. But we have a press packet that we have prepared, and we will ensure that you who are calling in get an electronic version of this information, and you'll be able to refer to it as we move forward. I will just ask a question of someone I have in the room. If any of this has been sent, my understanding is you've already sent some information today. So what you've received to date is a draft press release that we did for this event, as well as a fact sheet. The fact sheet is just a list of information that we thought that might be important for you as reporters to have as we look at some of our accomplishments under the waiver. The additional information we'll be sending you goes into more detail, and hopefully will give you some ideas about other kinds of programs or services that you'd like to talk to us about later. So with that said, I am going to turn this over to Brian, and we will get started from there.
Well, appreciate everybody joining us today, and we're all full of lunch and cake, having just celebrated our 2-year waiver anniversary. So of course, we're very pleased that we've been able to have this level of success, and look forward to doing that for a long time still. I guess if I were going to make an opening comment that is maybe our biggest message and what we take stock of is that I hope that when the General Assembly envisioned managed care, and in fact a public system of management in North Carolina, that this is what they had in mind. I feel like we've really committed to a certain set of values and a brand, if you will, that takes advantage of a very high level of commitment to communities, a lot of presence we have in all 23 of our counties, and on the other side of that coin, we have created the sophistication to be able to manage care in a capitated environment, just as any other managed care insurance company would. So it's balancing those two features that is something that we're really continually in the process of perfecting, but we feel very good about that. Be happy to talk with you about any questions you have.
Okay, Derek from the new topic here. I was just curious if Medicaid cuts at the statewide budget were going to affect y'all's operations at all.
Well, they will. In our budget, our capitation, and let me try to give a little deeper explanation, and I'm sorry if I bore anyone, but the service part of our budget is a capitated amount that once it's set, it's very unusual that on any sort of basis that would be changed. Okay? And there's a lot that goes into setting that rate that allows us to make reimbursements to providers. So the reductions that you've heard about in the budget have to do with fee-for-service Medicaid, which is not the part that we deal with. We've heard the sound bites about how Medicaid is out of control and it's broken. Well, the part that we have our arms around is not. In fact, it's very well controlled. We've demonstrated probably something on the order of $20 million worth of savings. So we are managing our part of the Medicaid budget very effectively. The parts where it still remains fee-for-service are aspects of general health care, by and large, that have received cuts in the recent budget. So those providers that are not part of our contracting system and system of care that we provide would not be affected. Okay, now, one slight caveat on that, there was a reduction in administration, which will affect us. And that's the part of us that is not the Medicaid program, but the state-funded program. So we're like an insurance company that has two plans. We have one for folks that have Medicaid, and we have one for folks that have no insurance. And that's where we have our greatest difficulty. So the admin cut on that side of our budget comes at a time when we have been given arguably more and more and more responsibilities from the state, but less and less funding to carry those out.
Okay.
This is Shelley with Smoky, and I guess one of the questions I have of those of you who are here with us today as reporters, in the fact sheet that you received as sort of in advance of this, were there any points or information that you that you saw in that fact sheet that you would like us to expand on or to provide you with more information about? It's sort of a very, I guess I'd call it a snapshot of some of our accomplishments, but we've been very proud that as a public system that we really have been able to be not only good stewards of Medicaid dollars, but also have had a very strong commitment to being responsive to individual communities and counties by having staff working in those communities and counties with both individual consumers as well as agencies and organizations.
Yeah, I'm glad you mentioned that, Shelley. I am guessing that people would not expect that close to half of our staff are individuals who are embedded in the community. And we have Jenny Pugh with us, our Senior Director of Community Collaboration, and Rhonda Cox, our Senior Director of Care Coordination. Their staff are very engaged with consumers and stakeholders on a daily basis. So, while we have a great respect for clinical needs and managing finances and making good clinical judgments, we also have a context for all of that is individuals living in the community. We talked quite a bit in our ceremony outside about the investment that we have in the community and the engagement that we have with stakeholders as being really a large part of our success, if you will, and certainly our brand. And the work that Jenny and her staff does and Rhonda and her staff does is really the proof of that pudding.
And provider network, we have a very large provider network department that really focuses on customer services and working with our provider organizations to make sure that they are using best practice treatment as they work with the consumers and families that we support them with funding for. Jeremiah, any questions for you in the room?
I was looking, I can't find the number right now, but I saw somewhere where it said 16 million spent since 2004 on housing, things like that. Can you just talk about what the specific efforts mean when you say affordable housing? What are those? What are those entail?
Sure, Jeremiah, thank you. One of the things that we hear a lot is...
And this is Jenny Pugh, just for folks on the phone.
Thank you, yes. And I do work with the Community Collaboration Department, and in that department, we have a couple of programs that touch housing. And what I was going to say was that In most of our conversations about supporting people with behavioral health or intellectual and developmental disabilities, we talk about housing first, that people have to have a good place to live, roofs over their heads, electricity to have power and have heat in the winter, and all of that is really kind of a precursor to being able to live a life of wellness. So housing is a very big part of what we do. We have a number of opportunities to help with housing grants for individuals, to help with housing programs in communities, and we're a part of something that is across the state of North Carolina, the Transitions to Community Living program, which is actually helping people who may have been living in congregate living settings for a long time without homes of their own. This project allows people to transition back to their home community or the community of their choice to live in their own home, perhaps for some of them for the first time in a very, very long time. So yes, Smoky Mountain does understand that having good housing and housing in a place that allows a person to be a part of their community is foundational to living in wellness and having good health.
If I can just do a quick follow-up, under the community collaborations, it provided 27 evidence-based trainings for consumer and community members to date for 2014. What does that mean? What is evidence-based training? What is that entail?
Sure. This again is in our community collaboration department. One of the things that we are really focused on is building stronger communities, building capacity in our communities so that we can have awareness of people who may be at risk for behavioral health issues, people who may need support and service. So what we do in our communities is offer these evidence-based programs. And Jeremiah, what that means is that any program we're offering has been proven through research to be effective. So when we go out and offer training, we know this training is going to be helpful to people. So some of the things that we're offering are mental health first aid for youth, mental health first aid for adults. The WRAP program, Wellness Recovery Action Planning, is a 2-day program that we do for people who just want to develop some skills for living a life of wellness. There are more programs that we're offering, at least 8 now, very well established evidence-based programs. Some of the programs are for individuals themselves. WRAP is for any person who wants to develop better skills for coping with stress, for living in wellness. The mental health first aid, the Darkness to Light Stewards of Children programs, these are all programs for adults and communities who can be looking out for children, youth, adolescents, or adults who may be at risk. It helps them understand how to identify someone at risk, how to intervene, how to offer good referrals, how to help link them to our service system.
Alternatively, and you'll see as a handout in your packet, we do, through the Community Collaboration Department, a lot of training focused on consumers, family stakeholders, but in order to help improve everything that is happening in the treatment world, the Provider Network Department also sponsors a wide variety of training to help improve the work of each provider organization using evidence-based practices, expanding their knowledge and ability in the kinds of treatment modalities that they use.
This is Marcus Cable. Brian, if I could just ask you to touch on one point that you mentioned at the event for staff today. You talked about the value of public management in behavioral health, mental health. And one of the cases I think you talked about was reducing the number of youth in restricted residential treatment, bring them into the community. Can you talk about how that relates to public management's ability to combine the financial discipline of a private sector entity with the community presence that you would expect from a public agency?
Be happy to, Marcus. It's really a good example that illustrates that balance between our responsibility clinically and financially. And of course, as I explained earlier, we operate with a fixed amount of money. Our capitation is limited, and we have to make decisions around how much care is best to be provided and what type of care should be provided and when it should be provided. And that's really the art of managed care. When you move from an unmanaged system to a managed system, it's a big difference for providers and for really all stakeholders. And one of the things we found was that over time, a number of youth have been placed in psychiatric treatment facilities, typically away from their home communities because of fairly significant behavioral problems that they had experienced. And these are very costly programs. And with Dr. Martin's guidance and Dr. Shiloh, we began a very painstaking evaluation of those kids and really started looking at the treatment plans, the expectations for improvement and discharge, and had a lot of questions about all of that. It was difficult to say that there was great benefit occurring from these kids being placed in these facilities. And we just kept digging and digging on that, and finally, recognized that we needed to change the continuum of care for kids that would be much less dependent upon these treatment facilities, highly restrictive treatment facilities in different parts of the state, in fact in other states, versus care that could be provided more locally in communities and reintegrating kids back into their communities. And I'm not even sure the numbers, and Dr. Martin has joined us, and Dr. Sheila were both very involved with this. One element of this that is important for me to mention, and then I'd like them to talk a little bit more about it, Mark, is it isn't about saving money, okay? Yes, we have a limited amount of money that we have to operate with. We move the money around. We change the services that are delivered so that, in this case, we are able to both reduce the length of stay of kids in these programs and avoid what I would say were unnecessary admissions. We're all about giving people the care that is really in their best interest, but we look at that very carefully. And I'm happy to say that in the 2 years in this one particular level of care, there was only one youth that was readmitted within 30 days who was transitioned out of this care. So of course the question that would beg, well, okay, so was this really better for kids? Was it really better for families? Were they able to sustain that lower level of care? Well, the answer is yes. Dr. Martin and Dr. Shiloh?
I guess yes, this is Dr. Martin. I would say the purpose that we found in this was that on the road to recovery, kids need a... Okay, I'll get a little closer. I think what we discovered was that oftentimes children were in programs where we were hearing that they had to, quote, complete the program, unquote. The trouble with that is that we want person-centered treatment, not designed around a program, but designed around the individual youth's needs. So really, before we took over a managed care organization, we had youth who were out of state for 1 and 2 years with no hope of ever returning home. And what we learned is that they were not being connected with their families in regular meetings. So by the process of advocating each month, both on the care coordination side with family team meetings with the provider, and on the utilization management side by my talking with the doctors and saying, what are the goals, what are we going to accomplish, and what does this individual child need to move back to his home community and have a meaningful life. That's what changed the dynamic. Dr. Sheila, do you have anything to add?
I think you summed it up perfectly. What I'd like to say is that working in collaboration with Dr. Martin and the clinical team and in pulling care coordination and looking at all of these consumers, we were able to really drill down and look at what type of treatment they were getting, and the goal was really to get them into, as Dr. Martin said, the community, look at what kind of treatment was being provided in the settings, and really start looking at the clinical presentation of children in these facilities, matching it to clinical best practice and understanding what the research showed about types of treatment for different types of disorder. And that's really the major growth in the last 2 years for us. A lot of real hands-on work with care coordination as far as looking at discharge planning for consumers and trying to facilitate getting kids out sooner. Not that all of them would get out sooner. There's kids who truly need longer-term care. And we also recognize that this program and this treatment is very, very valuable and needed for many consumers. Really, the goal was looking at the clinical presentation, family involvement, discharge planning, and how we can move them back home quicker. And I think it's been a team effort for everybody working together on it.
This is Rhonda. I think one other thing we would add is that we could not have done this successfully had we not had the partnership from social services and from juvenile justice, because they are often the largest percentage of their children often end up in out-of-home placement. And once they begin to hear and understand the research behind the outcomes for children that stay in long-term placements and have multiple out-of-home placements having typically poorer outcomes than children that get community-based services, they were very much a strong advocate with us at the table to support kids being served at home. So again, we could not have done that without some great partnership locally as well.
So in a publicly managed care approach, you actually have care coordination staff co-located in each county with the Department of Social Services staff. So these children are real children from those communities, and everybody wants them to return home in the best way possible.
Good question, Marcus, thank you.
I guess if I can just add one more behind that, then when I hear you talk about this specific program and the achievements, it sounds to me like it fits into the data we have in the background sheet and the infographic we're distributing that says to me, in 2 years since the waiver, you're effectively, Smoky is treating more people with more providers and still managing to bring the cost down by $20 million.
Correct. And again, it isn't by denying care that people should be receiving. We have a requirement to enable and facilitate care that is medically necessary. It's the organization that care, both in terms of the type, amount, and timing.
I have something to add about the denial, where I know that as an organization that's looked at that we are denying care, and I recently have been looking at some numbers in terms of the volume of authorizations we do in a year and requests we get yearly for services. We're upward of last fiscal year about 86,000 requests have come into utilization management for review for services. Full denials, meaning that we really felt that there was no medical necessity across the board for anything, was only 0.5% of all of those. But what has happened, obviously there are very, very interesting cases that do get denied for different reasons. We do partial approvals where consumers are felt to have kind of reached the capacity of programs, and in recognizing that, our goal is to make sure they're getting the right services. So we do about 1.5% roughly of all of those are partial approvals, meaning that we recognize that the consumer has needing to transition to another level of care. But what this information really means, I think, to everybody is that what Brian is saying is that no, out of all the consumers that we see, really there's not that many that are fully denied and not offered some supportive care.
Are there other questions or any points of clarification from either the press release or from the fact sheet that we sent you? And the other piece that I'll let you know is you get additional information from the folks at the Edelman company. We'll be happy to answer more questions or to set up any kind of follow-up interview with you as well.
Go ahead, Jerry.
Thank you.
Why don't you introduce yourself?
I'm Jerry Rice. I'm an advocate in the community for children and adults. My question is, you've done a good job on behavioral health. What's your heartburn going forward with physical health in the future with, if it passes that on down to you?
Well, that's a great question, Jerry. Jerry's a great addition to any meeting we're at, where he does an excellent job keeping us on our toes and doing a lot of recording. Well, that's our next mountain to climb, and we're really working diligently with partners like MAHEC, CCNC, Mission Health Systems to create a health plan that deals with, as the Secretary is fond of saying, whole person care or integrated care. I think we very much envision a change that would see all of healthcare being managed to some greater degree than it is now. We're a big piece of that, and for some of our folks who are members of our plan, they're dealing with chronic lifelong illnesses. Just as in the healthcare side, people suffer from chronic lifelong illnesses. We need to be able to look at, if we like to think of John Smith, we need to be able to help John Smith with every part of his life and provide the assistance, whether it's on the healthcare side, the behavioral health care side, in as seamless a fashion as possible. It's just the evolution in North Carolina that we've kind of come out first with this part of John Smith. And now what we're doing is working with healthcare providers to find a good way to fit what is done on the healthcare side with what we're doing. We hear a lot about that with the reform of Medicaid, and again, I'm very pleased with the progress we've been able to make. I feel like for a lot of good reasons, we have a well-established healthcare region in western North Carolina, and for no other reason than state borders and mountains and committed partners.
So I think the first question you talked about was the impact that the state budget would have on your operation, and if I recall correctly, you said it would primarily impact administrative positions. Do you foresee that having any sort of trickle-down effect at the local level at all?
Well, I wish there could be a really simple answer to that question. We already do many things for which we are unfunded. That's just true. And if we had Courtney Cantrell, who spoke earlier, she would be nodding her head now saying, yes, that is true. We're in the process of looking at our contract with the state and really getting to a point of saying, these popular statements that people utter, like me and others that wear suits and talk into microphones, do less with more. Well, we're past that. We can't do any less. I mean, we can do less, but it's going to be a lot less. We're going to have less money, and we're going to be able to do less in terms of our responsibilities with the state. How that works out exactly, I'm not sure. I don't know where a good line would be to draw around all of that. And that's an ongoing dialogue that we're having with DHHS that's really just beginning now. So, I guess, let's wait and see. We're very committed to doing what we do. We can't do it at a deficit and keep doing it at a deficit. Lisa Slusher, just off the top of your head, and she's our CFO. I know at one point we had created a graph that showed the reduction in state funds over the past, X number of years. Do you want to even try to take a guess at what that is?
I really don't know how much it's been, Brian. I know in administration, it seems like the last 2 or 3 years, we have sustained cuts from the state on the administrative side. A couple of years ago, we took probably about a $3.5 million service funding reduction from the state on the service side. So this year, we weren't anticipating any service reductions, and we haven't received our administrative funding reduction yet.
One other thing, and it's hard for people to keep this straight, the Medicaid funding that we receive, either for services or administration, we can't use that on the state-funded side. And the state-funded side is where we have such a discrepancy between the amount of service that is needed by people, the number of people needing service, the intensity of service, and a disproportionately small amount of funding.
Especially in our our catchment area, if you look at many of our rural communities, we have a very high number of individuals who do not have insurance and don't qualify for Medicaid. So we continually say our state funds are our most precious resource, and we're continually asked to do more and more with a dwindling amount of money. And as you know, it's dependent on the General Assembly to provide us with funds in that regard.
Yes, Shelley, this is Jenny. I'd just like to follow that comment. One of the things that Brian mentioned an hour or so ago in terms of areas of which we're very proud at Smoky is our work on the Crisis Solutions Initiative, which is a statewide initiative. And just to follow, Shelley, with your comment, you made a good point that we have citizens in this state who are eligible for Medicaid. We have some citizens who are fortunate enough to have private insurance that covers behavioral health. And then we have a lot of people who have no coverage at all. And when we think about the people who are in crisis, the people who have the most serious behavioral health needs, we know that more than 50%, more like 60% of them have no funding source at all. So that tells a great deal about the story about people in crisis, people in our hospital EDs. There is no funding source to pay for the care that they need.
This is Christina Carter. I'm the Chief Operating Officer. I would like to ask a question for you, who's in the room today and on the phone. I would assume that the understanding is that we are so committed. We are very, very committed to the average public citizen understanding the mental health, substance abuse, and individuals who have intellectual disability system better. We're so excited to be able to have this opportunity to talk about this. And what I would love before we all leave the room is to find out how you can help us and what do we need to do better to help people understand. Because, Robin Williams, right, just this week, my email box, every Twitter, Facebook, everything is full of what happened this week. We see the world, average citizens, families, all of us, everybody, it raises the awareness. What we are doing is we have the privilege to manage a system that helps many citizens who have these same challenges. We are struggling, and I say beyond Smoky, North Carolina, to really help the average citizen, family who may or may not have someone who's receiving services to know more about us, to have some basic understanding of who we are. And so to me and to all of us in this room, it would be very helpful. Are we giving you the right information? Are we giving it to you the right way? Because we are really, really trying. It may not be the biggest headline most day in your media that you represent, but what we see is, and I'm sure you know a lot about North Carolina, is that we have thousands of consumers who are showing up for the first time every day in the state, who have never been part of the system, who didn't even know we existed. Smoky's been around 42 years, who I still go out into the world and say, do you even know about Smoky? Do you know we have an access center 24/7, 365? A live trained person is waiting on your call to help you. And all the things that we have available. And I think that I would ask back to the media, help us help your readers, your followers, to understand more, because I hear two different statistics just recently, I don't know which university was out of in North Carolina. 1 in every 3 people in North Carolina either has somebody in their family or knows somebody who has one of these 3 disabilities. Nationally, it's probably about the same number. And so, you represent the citizens of these communities who are struggling with this. And we are all on such high alert based on the incident this week. And of course, we have a very famous person who, took his life. But it touches so many people what that represents. So I'm just very curious, are we helping you? Are we giving you, that we work, this is, to us, of course, we love to think we gave you the right information. But we also are trying to get it down to the, no disrespect to citizens, but to a level that the average citizen would just really know. There is a place called Smoky. There's a 1-800 number. There's people in every county, an office right down the street from you, who cares about your loved one or somebody in your family. So I guess I would like to just maybe share that, but also kind of in that ask the question. So.
Christina, this is Jenny. In sharing that, could we just make sure that the reporters do know the access number to call The 1-800 number is 1-800-849-6127. And that number can also connect a person who is in crisis with a mobile crisis service. So that 1-800 number is really good to include anytime we're talking about behavioral health and intellectual and developmental disability services.
Yeah, we really encourage that, just as something that you could include in every piece. So I am not hearing a lot of response sort of back to Christina, and I know probably it's the end of the day, maybe what we could do, I mean, if there are ideas, did anyone have an idea based on Christina's question? Or is this something that at least we can continue to be in dialogue about? And as we reach out to you and send you information, we've been trying to send you an article every month or give you some idea of activities, but are there things that we could do that would be more helpful to you?
Jerry?
Well, this is Derek from the news topic. I was just going to say that, obviously the more you keep in touch with me, the better the chances are of me, writing anything or getting anything in the paper, so.
Okay. Thank you.
Jerry, what do you think?
I think we've depended on the mainstream media so much that the technology in the world has changed so drastically that we need to think out of the box like you come out a while ago. And that is that we need to look at the ways that you might get emails from your consumers. I like to call them people. And get a network started where you could actually put it on a web where you could feed them information and they'd give you feedback, and it'd be an ongoing process, not just something that you're hoping the media might get them a message. And there's more ways than that, like you're talking about Twitter and other ways. The media is almost isolated anymore in the mainstream because they're so far behind when their stories come out a lot of times. So they're having to go to this type situation themselves. So instead of sitting in a room at a time like this, you could do it on the run and not have to be in this room. So that'd be my input.
Dash, and I didn't even pay you $5 for saying that. We appreciate it. One of the things, just for everyone on the phone and in the room, is we really have a commitment this year at Smoky to both looking at our website and making it a much more useful tool and something that is more interactive, and that's something that consumers, families, or the general world can find useful. We also will be looking into avenues related to social media because we know that's how the world communicates now. Just be patient with us because we want to make sure that we have these things thought through in a very careful way before we move forward. But thank you for putting that in. I think that's a good idea for all of us as we move forward.
All righty.
Thank you for your time. We'll be back in touch. Appreciate your calling in, and I very much appreciate your attending today. I hope you enjoyed the presentation, and we look forward to working with you in the future.
Thank you.
Thank you.
Thank you.
Thank you.